Marty. This meeting will be recorded just so we have a record of the talks that we have had here today. Thank you all for joining us on this strange day in American history. While the Associated Press has not authorized me to declare a victor in the presidential contest, I am able to welcome you all on behalf of the Department of Global Health and Social Medicine to the fourth of our Social Medicine Proseminars. We launched this series this year as a way of fostering conversation among our faculty and students, as well as among like-minded people within our community about what social medicine is, does, and could become. Social medicine has long distinguished itself from public health by its commitment to clinical care. Central to any understanding of this is the study of therapeutics. What do doctors do? How and why do patients and doctors have faith in their interventions? We are lucky at Harvard to have many scholars who have devoted their careers to this critical work, and you will hear from two of them today. Our first speaker is well known to many of you. Scott Podolsky is a professor of global health and social medicine, director of the Center for the History of Medicine at Countway Library, and a primary care clinician at Mass General Hospital. Ever since medical school, Scott has deftly managed to combine clinical work and historical scholarship. His many books and articles have transformed how we think about the history of therapeutics. For instance, many people credit antibiotics with transforming the treatment of infectious disease. While they have indeed done that, their early history was complex. When antibiotics first appeared, doctors had already created a successful system of serotherapy for pneumococcal infections. The benefit of antibiotics actually needed to be proven through clinical trials. Scott followed this work up with a third book, The Antibiotic Era, that documents physicians' struggles to ensure the rational use of antibiotics. As you all know well, this has only been partially successful, and we now face a growing problem of antibiotic resistance. Scott is now at work on an ambitious fourth book project, A History of Medical Journals in the United States. Our second speaker may be less well known to you, but could claim to be one of the most senior members of our department, having held an appointment here in the Department of Social Medicine in the 1970s. Jerry Avorn is a professor of medicine and the founding chief of the Division of Pharmacoepidemiology and Pharmacoeconomics at the Brigham and Women's Hospital. Early in his career, Jerry became concerned about the overuse of medications in elderly patients. This launched a two-pronged career. First, he built an impressive research center at the Brigham, now with 24 full-time faculty and expertise in many fields. He has authored over 550 papers, as well as a book, Powerful Medicines, that is now in its 11th printing. Second, he has worked as an advocate. To counter industry-funded marketing of medications, he created a parallel system of what he calls academic detailing, in which his team produced unbiased drug information for clinicians, including a fascinating set of what he calls unadvertisements. He founded a nonprofit organization that has implemented these efforts nationwide. Now, while many on our faculty have saved lives by improving access to medications, Jerry has likely saved an equally great number of lives by curtailing their inappropriate use. I should also note that Jerry played an important role in student activism at Columbia University in the 1960s. As an anti-war protester and investigative journalist, he bore witness and gave voice to a student movement that briefly took over the university in the spring of 1968, demanded a curricular revolution, and forced the university president to resign. His first book, Up Against the Ivy Wall, is both a fascinating account of this crisis and a powerful testimony to Jerry's lifelong commitment to advocacy and social justice. I hope you'll join me in welcoming Scott and Jerry to speak to us today.
David, thank you so much for that lovely introduction. Certainly want to thank everybody who's online for, in the midst of some other interesting issues going on today, for tuning in. And it really is such an honor to get to do this with Jerry, who was a enormous influence on me for many years, including during my residency at the Brigham, where he served as an attending, and from which I really imbibed lessons regarding therapeutics. And really is a supporter of me and Jeremy Green and a whole cohort of us working on the history of therapeutics. The very first iteration of this talk that I gave was in 2006 to Jerry's group at the Brigham. So I am super grateful, and I'm sure I will learn from Jerry a great deal more today. I'm going to share my screen. Let's see. Is that good? Oh, awesome, great. So today we're going to talk about this aspiration towards a quote-unquote rational therapeutics. And we're talking about the right drug for the right indication, for the right patient at the right time, at the right cost, and looking at the various sites of potential intervention that have been envisioned to inculcate a rational therapeutics over time, whether at the level of the marketplace, at the level of the prescriber with respect to either education versus regulation, or really, as certainly members of our department will appreciate, with respect to the material circumstances of that prescription itself. It's sort of staff and stuff and space and systems that Paul and many of us speak about. And the way that these varying notions of rational therapeutics have played on top of one another over time. And antibiotics and antibiotic resistance are, on the one hand, an important issue in their own right, but they're also a useful concept and tool to think through as we think through these issues. So I'm hoping that's what we can do over the next 45 minutes. And I'll start with a quote from Selman Waxman, who won the 1952 Nobel Prize for the discovery of streptomycin for tuberculosis, a little contested. And in a 1963 interview, stated, "What is the future of antibiotics? Antibiotics are here to stay. The antibiotic era will accomplish what nature has intended it to be, man's control over infectious diseases and epidemics that have plagued mankind since prehistoric times." In part, this is an era of optimism, and we can see a particular arc of sort of from optimism to pessimism, because 50 years later, Dame Sally Davies in 2013 wrote that basically because of quote unquote irrational prescribing, antimicrobial resistance is a ticking time bomb, not only for the UK, but also for the world. We need to work with everyone to ensure the apocalyptic scenario of widespread antimicrobial resistance does not become a reality. This is a threat arguably as important as climate change for the world. This was followed by an action plan in the United States, by the WHO. This was followed by the O'Neill report, which really put dollar figures to what this implied, and mortality rates. So the O'Neill report reported that if things were not changed by 2050, there would be 10 million people a year dying because of this. That would cost $100 trillion. By 2016, this led to only the fourth high-level meeting at the UN on a particular medical topic, in particular on antimicrobial resistance. And in all of this discourse, we hear metaphors of a post-antibiotic era or antibiotic apocalypse, and certainly the ever ubiquitous use of the term superbug. But these are not entirely new concerns, right? So the first use of the word superbug that I have found dates back to 1966. And I like the image so much that I end up using it on the cover of my book. But the notion of the therapeutic rationality and the sites of intervention for such therapeutic rationality have changed over time. And that's really what I wanted to be able to trace today. So I'll do this by first looking at the advent of the structure of pharmaceutical discovery, production, consumption, and especially marketing that the likes of Jerry and I have been wrestling with, and many of us have been wrestling with for a long time, really tracing that to the advent of the broad spectrum antibiotics of the late 40s, early 50s. I'm going to then look at a particular era, and a super important era of therapeutic reform in the 50s and 60s around the randomized controlled trial, the FDA, and the advent of drugs onto the therapeutic marketplace. It was a successful reform, but ultimately a very limited reform. I'll then look at the advent of concerns over antibiotic resistance, which really likewise date all the way back to the 40s, but really pick up steam in the 70s, 80s, and 90s. And again, started focusing attention more on the various influences on prescribing per se. And then really, in a way that I didn't do so much in the book itself, looking at a third thread, less about notions of excess, but more about notions of access, and attention to the material circumstances in which prescribing takes place and receipt of drugs takes place, and seeing how all this intersects before we can put some thoughts together about how this all could play out together. And it should take about 45 minutes to do. So I'll start with the advent of the broad spectrum antibiotics. And just to give you a sense of a timeline, right, the sulfa drugs came out in the 1930s. So David had mentioned that there had certainly been serotherapy and other forms of anti-infectives. But the sulfa drugs, John Lesh has actually called it the quote unquote first miracle drugs in the 30s. Fantastic book. Penicillin comes out during World War II. And again, Robert Budd and others have written excellent books, but Robert's book I strongly recommend. But I'm going to start with the advent of the broad spectrum antibiotics. Right, this is Lederle's aureomycin, introduced in 1948. That's chlorotetracycline. Park Davis's chloramphenicol, or chloramycin, in 1949, and Pfizer's oxytetracycline, or terramycin, in 1950s. And I love this graph. This is from the Kefauver hearings, and you can really see a literal change in scale brought about by the advent of the broad spectrum antibiotics. Right, so serotherapy, which my first focus about, was at most an $800,000 a year drug for literally. The sulfa drugs really do revolutionize companies like Merck, who can then bring all that money back in and transform their research base. It's certainly a transformative class of drugs, at most a $16 million a year drug. Penicillin is actually less profitable than the sulfa drugs because this was the product of a joint multi-company initiative during World War II. Nobody could patent penicillin. And folks like Pfizer got that message very clearly. And basically the head of Pfizer says in 1950 to the New York Stock Exchange, look, if you want to lose your shirt in a hurry, keep making penicillin, keep making streptomycin, which I should say came out in the late 40s. We need to create our own patented, branded drugs. And they do, right? And you can see literally aureomycin, this is, again, early 50s. These are enormous figures at the time, becomes a $60 million a year drug and really transforms these companies. Now, some of this, of course, is based on real medical need, right? There's so many conditions that these can treat that were untreatable prior to this. But it's also paralleled by a revolution in pharmaceutical marketing. And this marketing consists of mailings, journal advertising, and especially detail people, right? So Pfizer goes from having literally 8 detail people on staff in 1950 to 2,000 by the early 1950s. And these campaigns are run like military enterprises. They're described in the language of combat. This was an amazing cache of materials down at the Federal Trade Commission records at the National Archives that Robert Budd had pointed me to. And you can see the way they're running these like military campaigns. So the one on the left is a Pfizer note. It says, plans are being completed for the forthcoming regional meeting. Approximately half the region will blitz Memphis and the other half will blitz Birmingham simultaneously. Right, the one on the right is a rejoinder from Leaderly, where they're saying, holding the line in hospitals is a 24-hour ulcer. By and large, we're in good shape, but the sniping is terrific. Now, the head of the Pfizer campaign was no less than Arthur Sackler. And this note on the left is another memo saying, easy prey for terramycin. Those prey are not bugs. Those prey are doctors. They're saying you need to go down there and convert all your physicians to prescribing terramycin from these other broad spectrum drugs. And of course, this is an ethos and a strategy that will persist for many decades. And Jeremy Green, David Hertzberg, and I had written an article about how this lineage of marketing goes throughout the Sackler legacy from the early 50s through Purdue. The point at the time, which was recognizable to reformers, is that this was setting in motion this process of receipt of patient would go to the physician who has been inculcated to give antibiotics for everything. They would get their antibiotic for their cold and then expect it the next time, right? At a very embryonic stage of that therapeutic encounter. So already in 1954, Alan Hussar and Howard Holly are saying, quote, that the patient or his family demands a shot of penicillin is not the cause, but the product of indiscriminate antibiotic administration. But the real leaders in antibiotic reform at this time are right here at Harvard in part. It's Max Finland and Max Finland's earliest fellow, Harry Dowling. And so Max Finland is a legendary figure. He almost lived at Boston City Hospital for many decades. He was certainly the leading antibiotic researcher in this country for many decades. And what concerned them in the early 1950s was that you had this profusion of new drugs entering the marketplace to the point that physicians no longer had to worry about whether a antibiotic was indicated, but they were just wondering which antibiotic is indicated. And they saw this taking place within a regulatory vacuum. And that was their concern, right? And to give you a sense of that regulatory status at the time, just to do a very quick history on the history of drug regulation in this country, right? So the FDA is formed in 1906. This is the era of Upton Sinclair's The Jungle and muckraking around all the awful proprietary remedies that often contain cocaine or chloroform or heroin. And the Pure Food Drug Act of 1906 simply mandated that drugs contain what their labels say they contain. Okay, it was nothing explicit about efficacy or safety in that. That's where things were for the next 32 years. In 1937, we'd seen how we had the advent of the sulfa drugs. Sulfanilamide was a revolutionary drug. You can now treat strep throat effectively, but it tasted horrible. You could not get kids to take it. So the chief chemist at the Massengill Corporation had a bright idea. He said, well, I'm going to put in diethylene glycol into this and make it more palatable. Diethylene glycol is also a key ingredient in antifreeze. 107 children died. The chief chemist killed himself. This led to the passage of the Food, Drug, and Cosmetic Act of 1938, which mandated proof of drug safety, but not efficacy, at least not explicitly at that time. So that was where efficacy was always sort of in the background, but only as a relative term with respect to safety. So who could be adjudicating antibiotics or any other drug at a national level at this time? On the one hand, it could have been the AMA. The AMA had created its Council on Pharmacy and Chemistry in 1904 as a way of adjudicating a notion of therapeutic efficacy at the time. Basically, if you wanted to advertise in any AMA-affiliated organ, like JAMA, which was the dominant journal at the time, you had to have quote-unquote acceptance by the Council on Pharmacy and Chemistry. But by the 1950s, the AMA realized that through this policy, they were losing a lot of money. They were losing especially to the throwaway journals like Medical Economics or Modern Medicine, and they disbanded the program and really took a much more accommodationist approach to the pharmaceutical industry, such that between June of 1952 and April of 1956, Pfizer's mini journal, Spectrum, with ads containing enormous ads devoted to terramycin per se, showed up in every issue of JAMA for nearly 4 years. Okay, so the second agency that could have been regulating antibiotics in a more stringent fashion was, of course, the FDA. Its division of antibiotics was headed by the man on the left, Henry Welch. And Henry Welch is a fascinating character. He's a PhD chemist. He ran the FDA's division of antibiotics. He headed the major antibiotic symposia held in Washington, D.C. every year, and he ran the major journals devoted to antibiotics. And just keep that in mind. His partner in running those journals and running those conferences was the man on the right, who was Felix Marty Ibanez, who was a fascinating character. About 100 boxes of his material are at Yale. He was an emigre from Francoist Spain. He was a trained psychiatrist. He was a historian of medicine. He worked with Welch, and he also worked at the William Douglas McAdams Advertising Company with Arthur Sackler, all at the same time. All right, obviously, keep all that in mind. But both Sackler and Ibanez maintained a view about pharmaceutical advertising. They basically felt that this was not a conflict of interest, but that this filled an informational need. How do we get these wonderful products coming out of industry into the mouths of patients who need them? And that pharmaceutical advertising as education played a key role with this. And at the 1956 symposium, presumably with Finland and Dowling in the front row, Ibanez leads off. And he's talking about this problem of communication and says, Herman Biggs once made a statement that became the motto of the New York State Public Health Department. Quote, public health is purchasable. Within natural limitations, any community can determine its own death rate. So also might we say that medical communication can be financed, and within certain limits, each medical community can determine the degree of knowledge its members may attain. Who better than the pharmaceutical industry could organize, coordinate, and integrate on an international scale the vast and increasing knowledge on antibiotics, unquote. So Finland and Dowling are hearing this. They're already not super happy about what's happening with broad spectrum advertising, but they get increasingly concerned about what were known as fixed dose combination antibiotics. So basically you had penicillin as this first wave of antibiotics, followed by streptomycin in the 40s. You then had penicillin resistant bugs. You had the advent of broad spectrum antibiotics, which seemed to help with that, but you had bugs which were resistant to that. So industry said, well, let's take some of our existing drugs and combine them with ones coming through the pipeline. We'll create synergistic fixed dose combination antibiotics, which will both have A, wider microbial coverage, and B, perhaps have such synergism. And this was most famously embodied by Pfizer's sigmamycin, a combination of tetracycline and oleoendomycin. But you had folks like Dowling testing them, who found that A, yeah, well, any two drugs could be synergistic. They could be also antagonistic, and that was found to be the case at times, less than their component parts. And B, that you couldn't just do this as a fixed quantity, at least not for your general infections. There was a whole parallel level of research on TB, for instance, but that these were actually strain resistance. And they were starting to write about this, saying we should really be wary about how we accept these drugs. And then they absolutely get beaten to the punch at the 1956 symposium, run by Welch, at which Ibanez had led off, talking about the wonders of pharmaceutical communication. And Welch gives this talk, again, presumably with Finland and Dowling in the front row, saying, These fixed dose combination antibiotics are not a shotgun approach, but a calculated, rational method of attacking the problem of resistant organisms. It's quite possible we're now in a third era of antibiotic therapy. The first being in the era of narrow spectrum antibiotics, penicillin and streptomycin. The second, the era of broad spectrum therapy. Third being an era of combined therapy where combinations of chemotherapeutic agents, particularly synergistic ones, will be customarily used. And before Finland and Dowling can do anything, this goes out to every single clinician in the country from Pfizer. This is an envelope from the National Archives talking about the third era of antibiotic therapy, basically with the imprimatur of the nation's antibiotic czar. Well, Finland and Dowling are not happy. Right, so this is a picture from Max Finland's collection. This is Max Finland sitting there with Henry Welch. Everyone's smiling, looks to be having a good time. If you flip it over, though, it says Henry Welch and his harem, and presumably that was written by Finland. They're ticked off. And this is actually, people sometimes will say, "What's your favorite item in the whole Center for the History of Medicine?" For me, it's this letter. This is a letter from November of '56 of Harry Dowling writing to Finland and saying, "Look, we need to do something. We need to create a lobby that's going to compete with the large lobby of the pharmaceutical manufacturers. We need to mobilize." To me, this is the start of a critical reform effort. And in some ways, we all live with this legacy today. So Harry Dowling comes out of this, and in the summer of '57 gives a very famous talk before the AMA called "Twixt the Cup and the Lip." The cup being the crucible of pharmaceutical manufacturer, the lip being the mouth of the patient. And this is painted around a particular dystopia of irrational medicines, and says that, quote, "the techniques that have been used so successfully in the advertising of soaps, toothpaste, cigarettes, automobiles, and whiskey can be used as successfully to advertise drugs to doctors. With the inevitable disillusionment that comes with the failure of each useless modification to make any advance, the pharmaceutical industry will lose its prestige, and with this will lose its financial backing. It will fall, and the medical profession will be dragged down with it." Right? It's a particular dystopia. Finland takes a more pragmatic turn and says, how do we count this? And here I would contrast a methodological history of the controlled trial with a social history of the controlled clinical trial. Right? Methodologically, you could just juxtapose the case series with the RCT. But Finland does something different. He juxtaposes the testimonial with the controlled clinical trial. Basically, a testimonial to him was, okay, I'm a clinician. I'm happy to be working with Pfizer. They're going to give me a batch of sigmamycin. I'm going to use on 100 cases of sore throat. Everyone gets better. They can cite me. There we go. And everyone's happy for this. In using the word testimonial, he's pointing both to its epistemic concerns and its moral concerns. And to me, he's hearkening back to the 19th century, to the advent of quackery and testimonials that were being enunciated for those. Right. So he's literally hearkening back to Vin Mariani, which was this enormously popular medication in the 1860s, 1870s, 1880s. Coca-Cola was a knockoff for it. It's a combination of cocaine and Bordeaux wine. This is Pope Leo XIII, who was the most famous advocate and used as testimonials. And again, this is playing out in real time today, right? I mean, this is what Trump was doing in advocating for Regeneron. We see at play still these notions of what is our standard of efficacy. But certainly in real time in 1959, this was for a while an intra-professional debate, right, over fixed dose combination antibiotics, over criteria of efficacy. But it takes place at a crucial moment in 1959. And John Lear, who is the senior editor of the Saturday Review, writes an article called "Taking the Miracle Out of Miracle Drugs." And this is happening just as Senator Estes Kefauver is beginning his hearings on the pharmaceutical industry. And so Kefauver is a liberal senator from Tennessee. He gained fame in the early 1950s for taking on the mob. If anyone's seen The Godfather 2, those early scenes in the Senate, that's with Estes Kefauver presiding. He became Ali Stevenson's unsuccessful running mate for the '56 presidential election. But by the late '50s, he was really concerned with pharmaceutical pricing and apparent monopolistic pricing. The '50s had been the era of the wonder drug, right? You not only had antibiotics, you had antihypertensives, steroids, antipsychotics, minor tranquilizers. It was a real pharmaceutical revolution, but coming at an enormous cost, and he was concerned about this. Certainly now, we read in the paper all the time about the pharmaceutical industry being debated in Congress. it's almost a commonplace trope. At the time, this was novel. And both during the investigation and during the hearings, while this all started with concerns over pricing and monopolistic practices, it increasingly moved, I would argue, in large response to Weir's article, to the advent of pharmaceutical marketing and the inability of the FDA to adjudicate drug efficacy. And the most salacious day of the hearings occurred when they found out that Henry Welch, the head of the Division of Antibiotics, was involved in multiple conflicts of interest. That very speech about fixed dose combination antibiotics being the third era of antibiotics had been written by a medical student working for Pfizer and inserted into his lines. B, he obtained 7.5% of all advertising in his journals, 50% of all revenue of all reprint revenue, to the tune of nearly $300,000 in late 1950s figures. This becomes one of the first major conflict of interest episodes in American medicine. I don't think it's an accident. 1964 is really the first time that the New England Journal of Medicine starts discussing conflict of interest. Welch is forced to resign from the FDA. More relevant to our story, the Kefauver creates a committee with Max Finland on it, designed to tell us what went wrong with the Division of Antibiotics. And when the committee comes back, their first recommendation is that you need to empower the FDA to adjudicate drug efficacy. So the bill goes into place. It has that contained, and the bill is about to fall. It's a whole winding course over the next 2 years in Congress. It's about to fall off the table, and then thalidomide hits in 1962. And while all of S.D. Kefauver's original concerns about patenting and monopoly are pretty much taken out of the final bill, the mandate that drugs be proven efficacious based on adequate and well-controlled investigations by experts qualified by scientific training is written into law, and basically serves as the basis for the entire phased series of drug evaluation that we all know for the last 58 years. At the time, however, there's a dilemma. A, what do you mean by adequate and well-controlled? B, what do you do with the 4,200 drugs that have already been approved between 1938 and 1962? So James Goddard, who's the chair of the FDA, commissioner of the FDA, reaches out to the National Academy of Sciences to create the Drug Efficacy Study and Implementation. They basically create 30 expert panels, one of the first major times they were using such expert panels, to adjudicate on every drug. And 5 of those panels are devoted to antibiotics. By 1968, he's already followed by Herbert Lay as the commissioner. And in Christmas of 1968, all 5 committees adjudicating fixed dose combination antibiotics argue that they should be withdrawn from the market. And Lay makes that claim in the Federal Register. This creates a total firestorm. By this time, Upjohn becomes the major player rather than Pfizer. Upjohn's Penalba, which is a combination of tetracycline and novobiocin, was a $30 million a year drug. It's no better than tetracycline and perhaps more toxic. But Lay takes it off the marketplace, and Upjohn sues. They basically say, look, you're changing the rules in the middle of the game. Doctors are using this all the time. They write letters to every physician who then writes to the FDA saying, how dare you impinge upon our therapeutic autonomy? And this goes before the courts. In the midst of those courts, those court hearings, Herbert Lay says, look, these are the standards of evidence that I want. I want randomized controlled trials. And Upjohn says, look, we've got great things. We've got animal studies, in vitro studies. We've got historical controls. And I just love this verbatim transcript. We don't have just testimonials. We have a very extensive compilation of studies in vitro, animal, human, coupled with very substantial clinical experience. I think taking that together is a factor. Again, this should ring true to anyone watching the adjudication of therapeutic efficacy on the nightly news, right? I mean, this is Trump talking about hydroxychloroquine earlier this year. It's basically a testimonial. This is still being contested. At the time, however, this is going back and forth, and it forces Herbert Lay to really define what he means by a well-controlled investigation. And he basically says, look, what I mean is a double-blinded, placebo-controlled RCT. And if you can't do that, you better have very good reasons for doing so. And this winds its way through the court. And ultimately, the Supreme Court finds in favor of the FDA. This is, by that time, it's late 1969, early 1970, and it's a pivotal moment in many ways. Number one, I would regard this as the apotheosis of the randomized control trial at the top of the methodological hierarchy in adjudicating therapeutic efficacy, a position which it's really retained to this time. B, it's a pivotal moment in defining the FDA's ability to shape and unshape the therapeutic marketplace. But C, it's a particularly successful reform effort that really, I argue, dates back to 1956, but it's a very delimited, constrained area of reform. Right? No one, they're getting inappropriate drugs off the marketplace, but no one is shaping inappropriate prescribing per se. And that quickly becomes apparent. Right? So already by 1974, you have articles like, "This is medical progress," positing that between 67 and 71, against a 5% increase in the population size, you had a 30% increase in antibiotic prescriptions written. You see a total inundation of articles with titles like "The Rational and Irrational Use of Systemic Antimicrobial Drugs." And you hear the lamentations of folks like Calvin Kunin. Kunin had been Finland's longest tenured fellow, starting in the 50s. He is alive and well now, and just a remarkable figure. He'd been the chair of one of the panels that took all the fixed dose combination antibiotics off the market. But by 1978, he's already lamenting. He's saying, "A decade ago, some of us working in the field believed we had scored a major victory when the FDA removed fixed dose combination antibiotics from the market. This was no victory, but abject defeat. These drugs were almost immediately replaced by more expensive drugs and widespread usage of those drugs." And certainly Finland, and certainly by this time, Calvin Kunin were concerned about cost. They were concerned about adverse effects. They were concerned about superinfections. But by 1978, the biggest specter with respect to inappropriate prescribing was antimicrobial resistance. So I'm now going to take us on a different route and retrace from the 40s onward this concern over the advent of the superbug, over antimicrobial resistance. And I use it to show in some respect, these concerns are very old concerns. On the other hand, it took a long time to make them globalized in the way that they are today, and which I think points to just how tenuous that foundation could be considered. So I'll start. This was evident already with the advent of the sulfur drugs in the 40s, and then certainly with penicillin and its widespread usage by 1945. Right, so this is a letter written by a man named Roy Fraser to Wesley Spink at Minnesota saying, "Seems to be a tragic thing that self-medication with sulfur drugs and the consequent development of resistant strains should partly undo this great advance in chemotherapy. Now we have the perfect commercial buildup for the over-the-counter exploitation of penicillin. And we'll have penicillin toothpaste and penicillin shoe polish and penicillin breakfast foods and penicillin cigarettes and penicillin floor wax and lots of penicillin-resistant strains of pathogenic bacteria." By a decade later, even when such usage had been delimited to prescriptions, people were increasingly concerned about the advent of antimicrobial resistance. And this is a quote that I love from the Royal Society of Medicine in Britain, but this could certainly have been enunciated in the US as well. It stated that those deadly staphylococci, right, MRSA, those Manila in permanent possession of the field are not pirates or privateers accidentally encountered. They are detachments of an army. They are also portents. There are parallels in agriculture. We plow the fields and scatter insecticides and selective weed killers on the land, and we find we've killed birds and bees and flowers who minister in various ways to our health and happiness, with whom we have no quarrel. We should study the balance of nature in field and hedgerow, nose and throat and gut before we seriously disturb it. Again, we may come to the end of antibiotics. We may run clean out of effective ammunition, and then how the bacteria and molds will lord it. And that's 1954. And that same year, the same Alan Hussar, who I mentioned earlier, asked for a proposed crusade for the rational use of antibiotics. But there's really none coming at that time. The WHO convened a committee in 1959 on the use and misuse of drugs. But really, the WHO for the next few decades got mired in, from a laboratory setting, defining what's meant by a resistant bug in the first place. We certainly didn't see this happen in the US, where folks who could be leading this, like Max Finland, were really focused on the FDA and the marketplace itself. It certainly wasn't going to happen with the likes of Henry Welch and Felix Martin Ibanez. And really, in the US, antimicrobial resistance more than anything else became a market opportunity. Right? We saw that with sigmamycin on the right, and you see this when erythromycin was first introduced on the marketplace. It's used as a drug of choice when staph resist. And earlier it said MRSA. It was not quite MRSA yet because methicillin hasn't come out yet, but it was penicillin-resistant staph. So that's where things are, say, circa 1960, around the times of the Kefauver hearings. But almost immediately thereafter is a transformative moment. And it was the discovery by Soma Watanabe that antimicrobial resistance could not only be passed vertically, but could be passed horizontally, across species even, right? You call them R factors, we call them plasmids. Which seemed to really up the ante for antimicrobial resistance almost geometrically. And it's in this era that we saw that cartoon and the invocation of the superbug in 1966. Right, this is certainly the era of Rachel Carson and Silent Spring, and we see articles with titles like Environmental Pollution with Resistant Microbes. This is the era of guidelines being produced, the Sanford Guide. This is when, shortly thereafter, by this time, Jerry Avorn is introducing counter-detailing. But there's a real resistance to this, especially in the US, in a way that we would not recognize today, I don't think. Right? These were physicians who had taken had their ability to prescribe the likes of sigmamycin and Penalba taken away. And they weren't happy with being told that you're overusing antimicrobials. And this is a quote from a Texas physician when Medical Times asked 10,000 clinicians whether they're overusing drugs, and about half said no. I'll tell you, the only thing I think is being overprescribed, that is a hell of a big overdose of government being rammed down the esophagus of the medical profession. Like any other OD, it's either going to injure or kill the patient, in this case, yours and my profession, unquote. And this makes for great copy and certainly relates to our current political environment. But the point is that this was recognized at the time by would-be therapeutic reformers. And when they met in around 1974 to discuss this, premise number 2 was that physicians do not want the major ruling and antibiotic usage to come from Washington. And that's where things stood throughout the 70s. But by the late 70s, we had still more evidence of plasmid-mediated widespread antimicrobial resistance, salmonella, typhoid. And it's in this setting that Stuart Levy, who just passed away last year, convened a large-scale meeting actually in Santo Domingo in the Dominican Republic on the molecular biology, pathogenicity, and ecology of bacterial plasmids. And there, he and 147 scientists from 27 countries created a quote-unquote statement regarding worldwide antibiotic misuse. And this was a multi-sectoral approach to antimicrobial use in agriculture, use because of inappropriate prescribing, inappropriate regulation, or the absence of regulation. So it's A, multi-sectoral, and B, it was explicitly framed as a global issue. I would argue this is the first time it's really framed as a global issue. And this is an opportunity to really move things forward in the US. There was supposed to be a major meeting at the NIH. But this was the era of Reagan. This was an era in which the national, the NCID, the National Commission on Infectious Diseases at the CDC, was downgraded by 15%. And this major committee basically gets its legs taken out from it by the NIH. And you have folks like Jerry Avorn, who is very much involved in this project, lamenting that this was not done because of just science. This is probably being done because of pharmaceutical pushback. That's things were in the 80s, another time when you had an opportunity for this global mobilization, but it does not quite happen yet. But soon Jerry and Stuart Levy are joined by yet another really key player, and that's Joshua Lederberg. So Lederberg had won the Nobel Prize at the age of 32 in 1958 for his studies of bacterial genetic exchange, and had long been concerned with quote-unquote coming plagues, right? So in 1968, he had already been involved with reporting on Marburg virus, which is a cousin of Ebola. He actually gave it the name. But he really becomes far more agitated in the setting of HIV, right? ACT UP is literally acting up outside of his office when he's the president of the Rockefeller University. And he writes to also the just recently late Andrew Marshall, who was at that time the head of the Office of Net Assessment at the Pentagon, that there's no reason to believe that AIDS is the last word in what nature has in store for us. And he's influenced also by Stephen Morse, who's a virologist at the Rockefeller. And he's asked that year by President Francois Mitterrand to speak at a conference on the 21st century, its promises and threats. And he gives this talk on medical science, infectious disease, and the unity of humankind, where he really enunciates the rationale from both a pragmatic and a moral standpoint of why folks in the United States should be worried about global infectious diseases. He comes back and and leads a committee at well, I guess it's a committee at the Institute of Medicine on Emerging Infections. And this is published in 1992 in another pivotal book. And while it's mostly involved with viral threats, antimicrobial resistance gets taken along in this book as well, asking that the US government introduce measures to ensure the availability and usefulness of antimicrobials and to prevent the emergence of resistance. Yet another really important inflection point. We certainly see this in popular media, right? This trope of Time or Newsweek or Laurie Garrett having antimicrobial resistance on the cover really dates from this era. It's pretty easy to trace the increase of this subsequently over time. The WHO re-engaged with antimicrobial resistance by this point. It was all set to deliver this global strategy for the containment of antimicrobial resistance, and that was supposed to be released apparently on September 11th, 2001. And obviously got sidetracked. And so while there was certainly increasing attention over the ensuing decade, by 2013, you had folks like Otto Karsh and Ramanan Lakshmanaryan concerned that even with all this attention, coordinated action is largely absent, especially at the political level, both nationally and internationally. And that's the setting in which Dame Sally Davis releases her report in 2013, comparing antimicrobial resistance to climate change and to a ticking time bomb. Right? It's then followed by concerns in the US, WHO, at the UN. It's followed by the O'Neill report. It's followed by the World Bank report, which again puts dollar figures to this threat of antimicrobial resistance. And so a whole slew now. I mean, whereas in 1981, I could trace this to the Alliance on the Prudent Usage of Antibiotics as the main organization confronting this. You now have this, these are just 5, but you have dozens of organizations devoted to this, releasing dozens of frameworks about how to confront antimicrobial resistance. And all of these, you see a pretty similar typology about the measures needed to forestall a post-antibiotic era. Right, some of this is simply arguing for the improved infrastructure to even gauge how much antimicrobial resistance there is. But you also see certainly attention given to decreased demand, whether upstream attention to vaccination and sanitation, to education, to antimicrobial stewardship, to the types of diagnostics to undergird such stewardship and rational prescribing, and certainly to decrease usage in agribusiness and veterinary medicine. But far more money has been devoted to increasing the supply. And these have been related to both push mechanisms and pull mechanisms. So push mechanisms by either BARDA or by CARB-X, is how can we fund the early investigations of antimicrobials? And this is against the backdrop of a narrative that the pharmaceutical industry, which was built upon antibiotics in the 1950s, by the 70s and 80s, had largely withdrawn from leadership around devising new antimicrobials. They were no longer as profitable as making chronic disease drugs. Right? So how does one incentivize industry to re-engage this? So you have these push funds, you have pull models, which is if a company creates a new antibiotic and puts it on the marketplace, how are they not going to just simply then overmarket it so that it gets overused and therefore quickly becomes irrelevant? So how can we decouple, for instance, antimicrobial sales from antimicrobial profit for the company? So you have notions like a prize model for new antimicrobial discovery. We see that being recommended as well. And then perhaps most memorably, we see how do we make it easier for companies to study these drugs, to get them on the marketplace, with the notion that the FDA may in fact be the key hurdle in that process. And this becomes an important component of the 21st Century Cures Act. And the WWMFD is what Max Finland have done, right? Because here we see with the 21st Century Cures Act, which allowed, which reduced the stringency of what was required to get a new drug on the marketplace. We see this tension between two particular dystopias, right? One was the dystopia around irrational medicines per se. This was the concern of Finland and Dowling. The second is the dystopia of the post-antibiotic era. And we see these in direct conflict. I wrote articles about this. Jerry certainly wrote articles about this, about the concerns of what was being this new future with the 21st Century Cures Act. And we'll see where this all goes moving forward. But even still, even this entire narrative, whether it be the issue about either one of these dystopias, are still predicated on questions of excess, either excess drugs on our marketplace or excess drugs being prescribed. In the last few decades, they've been paralleled now by a focus on access. And again, tracing this history is likewise instructive, right? This was apparent immediately after the advent of penicillin. I don't know if anybody's seen The Third Man, but that's about, it's a fantastic, based on Graham Greene's screenplay, post-war Vienna, and really about black market penicillin at a time of lack of access to penicillin. And certainly if you take nothing else away from this talk, see The Godfather 2 and see The Third Man. But this certainly gives you a sense of where things were in the post-war era. And during that time, the United Nations Relief and Rehabilitation Agency was invested in promoting antibiotic production in post-war countries, particularly in Europe, but also in China, for instance. This is happening in the late 1940s. But by the advent of the WHO, the UNRRA is disbanded, and the WHO pretty much delimited its attention to antibiotic access. It did so in certain key campaigns. So certainly analogous to either malaria campaigns or the smallpox campaign, between 52 and 64, the WHO engaged in a massive yaws eradication campaign predicated originally on penicillin. We saw this certainly in the Cold War era with campaigns to use broad spectrum antibiotics to improve quote unquote childhood nutrition. That tension still plays out today. But mostly the global usage of antimicrobials was left to the marketplace. And perhaps predictably, there were real quote unquote irrationalities because of that. We had lamentations by the likes of Morton Silverman on quote unquote the drugging of the Americas, and articles showing, for instance, that of the quote unquote marketing of obsolete antibiotics in Central America, right? These same fixed dose combination antibiotics, which had been taken out of the United States. So in Sweden, whereas 9 of the entire antimicrobials, 2 were fixed dose combination drugs. In Mexico, out of 430 such drugs, 180 were fixed dose combination antibiotics. But these 2 dates are both instructive, 77 and 81, because 77 is also the advent of the WHO's first formulation of its essential drugs notion, right? Attempt to impose some kind of rationality on what types of drugs are responsible globally. Again, this is a year before Alma Ata, and this notion of how do we promote rational usage at multiple levels worldwide. But again, there was pharmaceutical pushback here. So by 85, the WHO creates a conference in Nairobi on the rational use of drugs, which gets significant pharmaceutical pushback. And really, I would argue the only global attention to such antimicrobials during that time is still around concerns over excess rather than access. But that 1981 date is also crucial, right? Because that's certainly the first recognition of HIV. And I argue here that the likes of Paul and Jim Kim and Salman and the concerns about HIV and TB and access to medications and how to bring this through around globally in rational ways starts to see not only from the TB and HIV literatures, but into the broader antibiotic discourse as well. It takes some time, I would argue, and this really needs to be traced still better. But we do see this. So folks like Recap, which is Otto Karsh in Scandinavia, by the mid 2010s are already talking about the costs of insufficient access. Right? They would state that there are 5.7 million people dying each year because of lack of access to antimicrobials. But at the same time, Karsh is a leader in concerns about excess. Right? So it really introduces this tension between access and excess that puts this pivot point at what we regard as quote unquote irrational therapeutics. And by 2019, we're now seeing the likes of Raman Lakshmanaryan and CDDEP, which have already written fantastic articles related to antimicrobial excess and resistance, really looking at access barriers to antibiotics in a way that, I mean, this is happening in real time, such that a bunch of us just last month wrote an article on this. These are mostly social scientists, really trying to place these tensions between access and excess intention. Right? How does one give attention to the local vis-a-vis the global in implementing any kind of a norm of appropriate antimicrobial prescribing? At stake in all of this is our very definition of what we mean by a rational therapeutics and where we see these pressure points for intervention. And I think it's instructive to go back to Selman Waxman's original talk, right? So originally I focused on what was there in yellow, but this hope that Waxman expressed in 63 was that with respect to antimicrobials, others less toxic and more active will be found. Costs will be reduced, side effects will be either eliminated or controlled. Physicians will have well-equipped labs at their disposal to evaluate each antibiotic and determine at once the particular antibiotic required for the treatment of a specific disease. Self-medication will be reduced to a minimum. Government control of antibiotics will be tightened so as to render antibiotics safer, more useful, and less expensive. So that first generation of reformers focused on a marketplace and site of drug entry as a site of drug entry in their notion of how to get to that. A later generation of reformers really started focusing by the late 60s and 70s on in defining rational prescribing, the right drug for the right patient, the right amount at the right time, and really looking at this relative roles of education versus regulation and promoting that. But certainly in recent decades, folks are starting to look at the material conditions in which prescribing takes place, right? These structural determinants of quote unquote rational prescribing. And whereas 6 years ago, we see articles like superbugs kill India's babies and pose an overseas threat, and with that focus on pose an overseas threat, we're now seeing increasingly in literature focusing on what's happening. What are the structural determinants of such superbugs themselves, right? So Alex Broom and Asa Doran can write about waste, structural violence, and antimicrobial resistance in India, right? Who is working on which drugs which put one at risk of antimicrobial resistance? Who is working and living downstream from pharmaceutical industries whose waste effluent is filled with resistant bugs? So we start seeing words like structural violence in this broader antimicrobial resistance discourse. It's no longer just about TB and HIV. We actually see articles now, this is last year, correlating GMP with antimicrobial resistance as a direct, I guess, an inverse correlation. And we see in the introductions, literally these invocations to Virchow. Right? These are not graduates of our department. These are, I actually don't know this group in Italy, but saying that the term social medicine dates back to Virchow and how social medicine and focusing on dimensions of poverty is a key aspect to considering antimicrobial resistance today. Access, excess, and structural determinants of health have really entered this literature. And we see folks ultimately, like Lori Denyer-Willis, I believe, studied under Arthur, working with Claire Chandler, really looking at antimicrobials in the context of the political economy of labor more globally, right? Condemning the notion of antibiotics as a quick fix, as a band-aid for inequity and inequality more broadly. For folks who are interested, there's now a growing group of social scientists working on these questions, bringing perspectives of sociology, of anthropology, of history to antimicrobial resistance. And I strongly recommend the Antimicrobials in Society site for anybody who's interested in these topics. I would certainly argue that historians have a key role to play within this group, but also more broadly, hopefully in framing where we've been and perhaps framing where we can go today as we really consider moving forward this coevolution of industry, of regulators, of drugs, bugs, patients, and clinicians alike. So thank you very much. I guess I hand it over to Jerry.
Okay, that is great. Thank you. I always learn a great deal whenever I listen to Scott talk, and I did again today, so thank you for that. And thanks to David for that very kind introduction. In a couple of minutes, and I want to see if we can also leave time for some conversation by the group as a whole at the end. But I wanted to just touch on some themes that Scott's talk brought out, and that, as he mentioned, we've been in our group thinking about for a while now. And I guess it is to start with, it's the way that, although culture is a really important aspect of any kind of medication use, it looms particularly large when we think about antibiotic use and misuse. And I'm drawing here on things I've learned over the years from Arthur Kleinman and Jeremy Green and Scott and David Jones in thinking about this interplay between culture and healthcare practice and healthcare outcomes. And as Scott mentioned, as we've been grappling with the idea of how can you deal at the prescriber level with antibiotic misuse and resistance and so forth, as we began to look into it, it became clear that there really was this very important overlay of the cultural expectations of the doctor and of the patient around antibiotics, which is much more rich and profound than, let's say, what a doctor or a patient thinks about beta blockers, for example. That antibiotics, for a lot of the reasons that Scott mentioned, loom very large in people's consciousness as these miracle cures that can kill germs that can otherwise kill you. And when we first started trying to deal with improving prescribing, and the very basic insight that Scott and David referred to, that the drug industry, and Scott demonstrated this admirably in the last hour, the drug industry really knows how to change medication use patterns much better than any 100 of us academics put together on a good day. And they do that because they take into account the doctor's motivations and goals and hopes and fears, as well as those of the patient. So when we first began our academic detailing work, really the first grant I wrote was in 1979, when I think I was actually on the social medicine faculty at HMS. I proposed that we would learn how to improve antibiotic use by doctors by using the approach of the pharmaceutical industry, but using it with a goal of improving the appropriateness of use rather than just improving product sales. And again, Scott's comments really demonstrated this interplay between what the companies want as companies, which of course they want, and what that might imply for doctor behavior and patient behavior and the larger ecosystem, which I'll get to in a couple of minutes. And so we began by interviewing doctors to understand what did they think they knew about antibiotics, but we also interviewed patients. And again, anything I've ever learned about how to improve medication use really came from what I learned from the drug industry. And we found some sympathetic people in industry who were willing to tell us how they did what they did. And they pointed out that focus groups are a really key way of getting kind of into that cultural machinery, both on the part of doctors and because antibiotics are such a big issue from the patient perspective, also from the perspective of patients. So we pulled together doctors and asked them, so why do you use antibiotics for an upper respiratory infection that probably is caused by a virus, which is one of the most common and sadly continuing causes of antibiotic misuse? And we learned a great deal, and we then trained our people in this academic detailing approach to go out and act kind of as unsales reps to docs to sort of unsell antibiotic overuse. And some of the things the doctors taught us was kind of based in a misunderstanding of a lot of the literature and ads that came out in the materials that Scott was referring to. One was that some doctors said, well, you know, even though it's caused by a virus, I think antibiotics might be a little effective against viruses. And, you know, these people probably went to the same medical school as Donald Trump did. Or if it's not going to kill the virus, maybe it'll prevent them from getting a super infection later. A lot of stuff that from a infectious disease perspective, you know, the what would Maxwell Finland have said perspective is just totally wrong. So we understood that we would need to tailor an approach to those doctors that would explain to them, no, antibiotics don't work against viruses and resistance is a problem if you overuse them. But then in our focus groups, we also had other doctors who said, look, I know that stuff. And just because I'm not on the Harvard Medical School faculty doesn't mean I don't understand the difference between an antibiotic, a virus and a bacteria. But I've got all these patients in my waiting room who want an antibiotic because they think that's what they need for their upper respiratory infection. And I can either spend 20 minutes giving them microbiology 101 and explaining how a virus is different from a bacteria and antibiotics only work against bacteria, or and then have them leave angry and maybe go down the street to this other young doc who's setting up a practice and get the antibiotic from him or her. Or I can just give them the antibiotic, they leave happy, I've only spent 5 minutes and I can get on with all the other patients in my waiting room. So we realized that for those doctors, a lecture on microbiology 101 was not what they needed, but we had to get kind of under the hood of their particular social and cultural experience with those patients. And so we created back in 1980, 81, what I think might be the first direct-to-consumer unadvertisement, in which it was kind of inspired by some of the docs in our focus groups who said, look, if you can give me something I can give to the patient as easily as I can give them a prescription and make them happy, then maybe I'll listen to what you're proposing. So we put together this why you don't really need an antibiotic leaflet for patients. And the doctor could write the patient's name on the top and they could sign their name on the bottom. And it talked about how if your doctor were to give you an antibiotic, you could be growing superbugs inside your body that could then be dangerous. You could end up with antibiotic-induced side effects, whether it is a rash or diarrhea or thrush. And all these reasons why it's better. All these reasons why it's better, your doctor's doing a better job to not give you an antibiotic. And so we equip the doctors with those. They could write this unprescription to the patient and then be able to have the patient leave happy without an antibiotic. And I think the reason we were able to understand how to do that was because of all the focus on what is the cultural and social context of the prescribing experience that people like Arthur and others who are involved in thinking about medical anthropology have really been dealing with for decades. The other piece, though, I wanted to mention briefly is, speaking of culture, it's not just the culture of the doctor and the patient, it's this really disturbing cultural development that Aaron Kesselheim in our group and I have been worried about, which is the nation asking itself the question, how do we create incentives for the pharmaceutical companies to come up with new antibiotics that'll make it economically attractive enough for them to do it? And then there's all these erudite and complex models about how to create economic incentives for the drug industry to come up with new antibiotics. And that really is frustrating for a number of reasons. One is, as you all probably know, antibiotics are not, at least in the current era, a very economically attractive thing for a drug company to work on, because if they do come up with an antibiotic that's good at dealing with a resistant bug of the kind that Scott was talking about, all the ID docs, sort of the Maxwell Finlands of the current day, will come along and say, that's great, how about you try to never use it? And we'll keep it in reserve, and that way we'll have it when we need to use it against a resistant bug, which is, of course, exactly the right thing to say. But from an economic model, from the perspective of a drug company, that ain't a statin. That's not a great winner for their shareholders, because who wants to spend a lot of money developing a drug that all the experts then say, try not to use this? So the reason that it perturbed me to think about how our culture and economy and health policy enterprise kind of default to the head-scratching problem of how do we make the development of antibiotics more economically attractive for drug companies. And of course, the other aspect that's so economically unappealing to a drug company is, unlike a statin, which you take every day for the rest of your life until you die, even if you can get beyond the ID experts saying quite appropriately, try to never use this, if you do ever use it, you use it for maybe 7 to 10 days and then you stop. So again, this is the exact opposite of a recipe for an economically attractive product for a company. And so the way I've always thought about it is, why are we spending all this energy and effort in trying to answer the wrong question? That this is never going to be an economically attractive thing for drug companies to develop. And all the kind of bad answers that come out, like you make it unbelievably lucrative by giving this very, very high reimbursement rate to drug companies, which you then get the hospitals extra high reimbursement rate if you have a pneumonia patient that you had to treat with a antibiotic for a resistant bug. All that seems to really be going down the wrong path. And then I've thought, in wondering about how to deal with these issues that Scott was talking about, something that, having been at HMS now since I came as a student in 1969, all the really, really smart, committed, dedicated, creative people who work in clinical research and basic science, who did not, at least, until recent years, go into that line of work because they wanted to get rich. They wanted to deal with an issue like my late friend Stuart Levy, whom Scott mentioned, did. How do you understand why tetracycline resistance can jump from one bug to another? And Stuart didn't do that to make money. Stuart did that because he was a committed, creative scientist who was concerned with studying a problem that was important to patients and scientifically important in its own right. And it is that approach to drug discovery that everybody who is concerned about the best economic model for making this attractive to the companies seems to kind of skip right over. And my sense is the way we're going to deal with the very terrifying prospect of superbugs through the overuse of antibiotics is by just having lots of NIH funding and Howard Hughes and foundation support go to docs who are working on often obscure aspects of microbial resistance, who will, left to their own devices, if they have enough support, come up with important answers, even if they can't make a bundle on it. And the fact that our science policy so often reverts to the idea of we need to figure out how to make this more economically attractive to companies, I think misses the perspective that a lot of us are not in this business to get rich, and a lot of some of our best scientists are doing very good work without the economic incentive that seems to be behind a lot of policymakers' attempts to encourage antibiotic development. I wanted to come back just kind of in trying to wrap up to that remarkable point that Scott raised about the Sackler family. And I find it just exquisitely troubling that the same man and people who gave us the over promotion of OxyContin, and for which literally not a month goes by without some settlement announcement or new lawsuit announcement in the papers about the opioid epidemic, how they kind of honed their craft, as Scott has taught me, on thinking about encouraging antibiotic overuse. And then, of course, applied that when they came to own Purdue Pharma to use those same approaches to persuading people that we need to also overuse opioids. And it would have been weird enough if it was the same approach. It is even weirder that it was the same guy who was doing mischief on both of these fronts, and in a sense, creating epidemics in his wake of antibiotic overuse on the one hand and of opioid overuse on the other. And it just is another example of how the mistaken approach of medicines are basically about business and how it can be increased can not only waste a lot of money, but can also create problems for an entire population. And the superbug, and Scott, I love that cartoon of the superbug. I'll be having nightmares for weeks now, although I have a lot of other things I'm having nightmares about too when I read the papers. But the idea of superbugs, I think, is going to come back to the public's consciousness in relation to COVID, because I don't think that people really understood that infectious diseases can sweep through a society and create just unbearable, widespread disaster, both clinically and economically and socially. And I think to a large extent, many of us bought into the idea of, well, thank goodness all these infectious diseases are behind us now that we've got all these good drugs. And COVID really was a reminder that there are some things that science is absolutely ineffectual in trying to fix, at least quickly and cheaply. And antibiotic resistance to all known drugs, which Paul Farmer has spoken very cogently and terrifyingly about, whether it's multi-drug resistant TB or something like Ebola that is more easily transmitted, that is definitely now a little bit more in people's consciousness, although just as the possibility of a respiratory agent pandemic was kind of out there in the minds of many smart people, starting from Bill Gates, down to Tony Fauci, for many, many years. As a nation, we never quite grappled with it. And now, of course, we're still not grappling with it, even though it's totally in our face. But this idea that antibiotics have vanquished the risk of infectious disease is, I hope, going to get eroded a little bit and maybe have people think more sensibly about resistant bugs, whether they are bacteria or viruses or anything else. So I guess to wrap up and make sure that we have some time for some conversation, what I loved most about Scott's presentation was reminding us that, as Virchow said many, many decades or a century or so ago, that medicine is at its root a social science, something that the people on this call and the department understand very well. And that while there may be people in labs who can think about, plasmids or messenger RNA in total isolation, at the end of the day, illness in general and infectious disease in particular are deeply embedded in societies and in cultures and in economies. And again, the kind of brutal lesson of that is COVID, but it's come up as well in all the examples that Scott gave us. And this is a great time to be thinking again about how do we deal with infectious disease, knowing that they really are something that is a potential threat to all of society, and that we're not going to just fix it by having a better business model for companies or doctors or patients. So that's what I got. And I think both Scott and I would be happy to entertain questions, comments, objections.
I'd like to thank both of you for those wonderful and thought-provoking talks. I think they both succeeded extremely well at demonstrating the ways in which social medicine sits at the intersections of medicine and public health, concerned about everything from knowledge production to corporate interests, and the awareness that we need to figure out ways to change knowledge, to change behavior, and to change context if we're going to achieve better outcomes. So we definitely have time for questions. People can either raise their hand or wave in the camera or put something into the chat, and we will be happy to respond to questions that people have. I see that Vikram had already put one comment in the chat that Jerry had already responded to in some ways. You know, the fact that there are so many parallels in this story between antibiotics and opioids, which makes perfect sense in retrospect. I don't think anyone would ever have anticipated.
I should say in our article, we were, from a legal standpoint, we were very careful to say that I know it was Raymond and Mortimer Sackler who created Purdue, and that Arthur Sackler was not ostensibly the owner of Purdue at that time, but that nor was Arthur Sackler the only person creating the revolution in pharmaceutical marketing in the 50s, but he was a key figure. And has been well known as a transformative figure. And yes, that playbook was established by the early 50s, and it certainly came out again in the 80s with Purdue for sure.
Salman.
Thanks, Scott and Jerry, for a great presentation and discussion. I just have a question. You know, I'm on one of these committees that looks at antibiotic resistance in the country, and it's always interesting because you go to a meeting and there'll be something about how we're trying to get pediatricians to prescribe less antibiotics for kids with earaches for the reasons that Jerry laid out. And then at the same time, there'll be a presentation on how 70% of the antibiotics being used goes into the food supply chain, and that it's likely that the colistin resistance that we're seeing came from, China or Russia or whatever country happens to be, identified as the source because they actually use the drug. And these plasmid mediated resistances just jump, and around. And so I just wonder, I'm not trying to give pharma a pass because I think you've presented, a century of data that shows that there has been a concerted effort to get people to use things. But now we're facing the agricultural use of this. And what do you think of the role that's playing, and how do we counter that?
Okay, I can take a quick stab, and then Scott. You're absolutely right that the number that one hears is usually well over 50% of the gross tonnage of antibiotics is used in agriculture, on feedlots and so forth. And if you just think about it microbiologically, it almost doesn't matter whether it's getting into the ecosystem via feeding chickens or pigs or having doctors write prescriptions at much smaller doses, it is still out there breeding resistance. And that's been the case for a long, long time. But again, I wouldn't say that kind of gets pharma off the hook, because that is a major sales outlet for them, and that they are also prominent in saying, what's the fuss about the use of antibiotics in agriculture and animal husbandry as well. So again, and of course the farmers love it because apparently it's a way you can grow your chickens or pigs or whatever, faster and better and bigger. So yeah, there's an economic aspect of that as well. And it's been tough politically for people to push back against that. But yeah, literally 50% or more by weight of antibiotics in this country are being used in animals in routine, not sick animals, but just routine agriculture. Scott, do you want to add to that?
Sure. It's funny because in the intro to my book, I have a specific caveat saying, I know there's a whole parallel story about antibiotics in agriculture, and someone else is going to write that book. And they did. Klaus Kerschel wrote a great book called Pyrrhic Progress, which compared antibiotic uses in pharma, in pharma industries in Britain, Germany, and the US. And so a couple ways to answer it. Number one is, yes, while the gross tonnage is certainly more prevalent within agribusiness, the question still remains about which is more relevant to the strains and the resistant strains that we care about, right? So whereas, and this is not to say that antibiotics in agriculture shouldn't be phased out. I think they should, but are they necessarily leading to the types of bugs that we're seeing in the ICUs at the Brigham or MGH? And I think that data is a little fuzzier. It's its own unique story, right? About how the entire, again, post-war discovery of antibiotics as growth factors in the late 40s, early 50s. Those same drugs that I was showing, oreomycin, were being widely advertised in farming journals, in veterinary journals, and transform farms from small individual farms to these mega farms that we see today, predicated on animal density and the usage of antibiotics in agriculture. So you're asking those industries to transform basically how they create their food supply. There's trade-offs there as well. So I mean, having said all that, absolutely I'm in favor of phasing out antibiotics which may have any human relevance whatsoever. The question whether that's the sometimes those are put in juxtaposition or almost in contrast to usage in humans. I think it's complementary. Hard to figure out which one is really contributing more to the bugs that we care about. But Klotzker-Shell's pure progress is excellent, as is Mary McKenna's Big Chicken.
They probably both require a similar type of regulation, as you're saying, advertising control and things like that.
Yeah, and we see, I mean, the word One Health, right, enters the literature around 2004, and you have this tripartite agreement between the WHO, the FAO, and the OIE, right, animals, food, and human health. So it's certainly recognized increasingly as a shared problem. And being and almost all, I even showed on the typology, almost any major document today, except for mine, would show them all being discussed in relation to one another, for sure.
Other questions?
Hi, this is Vikram. What a fascinating account, really. And I think the remark that was made about the opioid crisis is one that even I was observing. And my question really was, what is it about the medical practice profession, apart from commercial interest, do you think that has led repeatedly to the irrational use of medications over the last 50 years? The commercial instinct, of course, is one that is obvious, but is there anything else? And why does this, for example, also happen in places where doctors don't necessarily earn from their prescriptions? So, for example, in universal health coverage systems.
Scott, you want to start and then I'll follow up?
Sure. And I must say, whatever answer I give now, I learned from Jerry, meaning in part, this dates back to the 50s, where the medical profession basically outsourced much of its education around therapeutics to the pharmaceutical industry, whether that was being informed by advertisements in journals about the newest drugs and their uses, or even to the infiltration of CME with industry oversight from the 70s especially onward. So I think that's a big part of it, and the very notion that I should pay for my own to go to CME when someone could actually be sending me there, or somehow subventing the cost of that CME, was built into the medical educational infrastructure around pharmaceuticals for the last 6 or 7 decades. And you had entities like the Medical Letter, you had people like Jerry Avorn countering that, but they are outgunned in a lot of ways by enormously resourced folks who want to educate physicians around new and emerging pharmaceuticals, especially. Right, and that was the whole mega industry of detail people, again from the 50s onward. And again also, and I'll stop in a second, but built upon this notion, and you talk about cultures and structures, this culture of the notion of the autonomous physician. Who's anybody? Who's Jerry Avorn to tell me how I'm going to drug my patient? I went to medical school. I know my patient, and I mean I was on the house staff when we were at the Brigham in 1998. Trying to prescribe a quinolone, and you get this pop-up thing from Jerry Avorn and his group saying, "Do you really want to prescribe a quinolone?" And I remember one of my colleagues saying, "Who the hell is Jerry Avorn telling me what to do?" We were like residents, so you can imagine, how that culture of autonomy matched up with this outsourcing of our educational status, really, I think help foment that system that we see today.
Right. Totally agree with Scott's point. And I think it is correct, Vikram, that there is often not any economic incentive for the doctor to prescribe well or badly. In fact, one could argue that the fact that there's no economic incentive to prescribe well is maybe a problem of its own. But it's not like when doctors misuse drugs, it is because of some economic advantage. Part of it is sort of how we understand reality and science. And as Scott mentioned, the industry has been more than willing to come in and tell us how we should understand science and clinical problems. Again, the opioid example is another good one in that, as is widely known, Purdue Pharma in marketing OxyContin created this whole culture that we're undertreating pain, and what's your patient's pain score, and if you don't really get rid of all their pain, you're not being a good doctor. So part of that is the same with antibiotics, that the expectations that are created totally apart from any economics for the doctor are what drives prescribing. And I would differ a little bit with one aspect of Scott's answer where he said it goes back decades. I would suggest that it goes back millennia, in the sense that ever since Hippocrates, doctors have also had this other issue, which is we want to be able to feel like we are effective in helping our patients. And that was the case, 1,000 or 2,000 years before there were drug companies. We feel like we need a tool. We went into this business because we want to help sick people get better. And we need whatever we feel we need, whatever we can offer them, whether it's an antibiotic or an opioid or anything else. And of course, the companies are fully aware that they can feed into that. But even if there were no drug companies, we would all be tempted to prescribe things that don't work. And in fact, as Scott knows better than I, up until about 1950, most of prescribing was for stuff that didn't work. And that's because of the orientation of people who go into medicine and our heartfelt desire to do something that will help the patient and that they will be grateful. And if it doesn't work, then that's maybe not at the center of our concern.
Yeah, I totally agree with everything that Jerry just said. And, again, invoking the title of Jerry's book, Powerful Medicines, you can imagine where you are in 1950. You suddenly, as a clinician, have aureomycin at your command that you can give for anything, and you're going to give it for almost anything, in a way that you didn't have it certainly 10 years ago. This is often thought of as the golden age of golden age of medicine, right? This empowering of practitioners like me. I mean, I get it, and I'm a primary care physician. You want to, as exactly as Jerry says, that speaks so clearly to me. You want to be able to do something for your patient, and you can, these tools that were put in the hands of clinicians in the 50s literally led to what Robert Budd, the great historian, called the rebranding of medicine. Right? Penicillin becomes part of the medical brand during that time. And it's a hard thing to shake.
And it's not accidental that a number of those remarkable articles that Scott illustrated for us, not the ones in Any Jam or JAMA, but some of them were from, Look magazine and other lay publications, because at the same time that this was being promoted to docs, it was also being promoted to society, that we've now got these powerful drugs and we're going to transform infectious disease. And that was right to the consumer at the patient level.
Looks like Alan just put in a comment. Alan, do you want to say more about that?
Sure. I've always very much admired this early paper that our colleague, medical anthropologist Jean Komaroff, wrote in the mid-1970s. And she did an excellent ethnographic investigation of the use of antibiotics in a National Health Service practice. And her central argument was that this was a strategy for enhancing authority in the doctor's knowledge and capability, as well as in biomedicine overall. So having a pill, even a pill that won't work, that a patient wants, that a doctor provides, really had this kind of, if you will, gift relationship that made doctors very powerful, and it made them feel very powerful often in the face of diseases that they couldn't really treat. And I think, obviously Scott and Jerry have both captured this, but one of the interesting points is that, even though this was recognized easily forever, it has remained such a deeply persistent problem in prescribing behavior. But it's really worth taking a look at her paper because she was onto this at such an early time and used ethnographic techniques so successfully in trying to understand it.
I had a question for both of our presenters who gave such a wonderful job. First of all, it's great to see you, Jerry, here. You were here when I came back in 1982, and we should never have let you leave to go to the Brigham. And Scott, it was wonderful to hear you. So I'm going to ask the question, what's to be done? Because so we've had the criticism of the pharmaceutical industry, of the medical profession, basically of the media, that we haven't talked in detail about media and its relationship to families and individuals. And the families and individuals have also been brought up as a problem. So we have the failure of the regulatory state, the failure of the economic system that we're in, the failure of as was nicely put, cultural factors. So then what is the point of entry for doing something more effectively about this?
Wow. Okay, we are toward the end. Arthur, great to see you as well. And thanks again for all that I've learned from you over the years. A very super quick answer is that in the US in particular, but also in many healthcare systems, but especially in ours, nobody is really in charge of prescribing by a given doc. We don't really have health systems. And in the case of opioids, whatever you prescribe, unless you manage to run afoul of the law, people are not going to really come after you. And the same with antibiotics. If we were to have a healthcare system or systems in which a doctor's prescribing was just seen as something that ought to get looked at and make sure that the doc is not giving an antibiotic to every patient with the sniffles or any number of other examples one could think of, and approach it, I would hope, educationally and not punitively, that would at least be a mechanism for looking at a way to improve medication use. But we are far from that, but that may be a goal that would address some of the questions that you raise. Scott?
Oh, it's an easy question. No, I mean, it's incredibly difficult question. And in fact, it's what made me sympathetic to understand why Finland and Dowling in the 50s, when they're confronted with widespread resistance and usage, focused so narrowly, because they could. I mean, it was something that they could actually operationalize and intervene upon, even as important as it was. It certainly demonstrates just how multifactorial this is, and these differential impacts of quote cultures and structures. I mean, I will say, what I've learned from you and Salma and Paul was just how important structural determinants were, whether in the United States or whether globally, right? And we could focus on all these levels, but structurally, in the United States, if I have 5 minutes with each patient, that's going to make me more apt to use an antibiotic for someone coming with a cold than if I have 15 minutes with a patient, or how incentives are aligned is going to structure it, let alone how antibiotics are prescribed in the world where there may not be the type of diagnostic and primary care infrastructure that we would like for the delivery of drugs. So, I mean, I think it's why all these answers have been these narrow answers, whether it's around the issue of regulation, or whether it's saying, let's just get more drugs in the marketplace and keep that arms race going, because that will just stay one step ahead. I think when we truly go there, the antibiotic story that I described matches up with the antibiotics stories that Salman and Paul work with. And then you're really going to Alma Ata, you're going to saying, we need to transform how healthcare is envisioned and delivered worldwide if you really want to take the implications of this. What is a real rational therapeutics? It's one in which everyone has access to the appropriate infrastructure, the appropriate education to have the right drug for the right person at the right time. So it's daunting. Yeah.
And Scott,
I was just going to say one quick last thought on that is that there is a ray of hope in that we do have a model in tertiary medical care facilities that actually works pretty well, which is that there are some antibiotics that you can't just prescribe because you want to. And we, the infectious disease divisions enforce that and kind of require that there be the thoughtful process that needs to go on. And the term that I love, antibiotic stewardship, is the reason for that, that we are all kind of stewards of these very powerful drugs in the same ecosystem. And so we've enforced ways that anybody who wants to use some latest treatment for MRSA or whatever can't give it to whoever they want just because they feel like it, and they've got to get ID's permission. I think that's a nice constructive approach that maybe we could do on a broader scale.
So Jerry, just very apropos to that, unfortunately in the world of tuberculosis, you and Scott probably well know that for drug-resistant TB, there was a bottleneck that had to go through the WHO. And that bottleneck really stopped a lot of people from getting care. And, if you look at the case of India, a lot of people were saying, oh, we shouldn't allow second-line drugs to be prescribed by non-TB doctors in the Indian market. And we're pushing the government to narrow it.
Right.
But everybody with extrapulmonary TB was getting care in that market because you couldn't get it from the government. They weren't treating extrapulmonary TB. And so, you start to look at it, and yes, in a perfect system, you could start to have these centralized nodes of control. But when you don't have that, you actually, these are the only care outlets people can get. That's number one. And then number two, what's happened with TB is that people have used the same antibiotics for 50 years. It's now led to drug resistance. And so the innovation that you see when somebody is saying, hey, why don't I try this other combination, which risks doing something bad, also risks doing a very organic innovation on a use of a drug. So it's a double-edged sword, right? I can prescribe anything I want to anybody for anything, but presumably you're trusting my reasoning, and we'll find out that some drugs work better for ways that they weren't intended. Right? So I know that that's a slippery slope, but I just think that over-regulation also has its downside.
Totally. And it brings us, and again, I could go on till nighttime because when I stop, I'm going to watch the news, and I don't want to do that. But the other interesting question that's been in the field for ages is, to what extent does misuse provoke and permit resistance development? And that it is, as you say, Solomon, a two-edged sword. And not that I'm advocating having the WHO need to give permission for anything, because raises its own problems.
And this conversation is actually a very good one to both thank everyone for participating and also to welcome you all to our next talk in 2 weeks, where Arthur Kleinman and Vikram Patel will talk about the challenge of democratizing care. And you can see the tensions about this in this question of how we should make antibiotics both accessible and safely controlled. And I'm sure Arthur and Vikram will lead us in a wonderful conversation about the broader challenges of that issue. So thank you again for everyone, and we look forward to seeing you in 2 weeks.
Okay.
Thank
Thanks,
you.
Scott. Thanks, Jerry. This was great.
That was great.
Thank you.
Appreciate it.
Glad to do it.
Bye-bye.
Thank you.